Go now.
Hello, colleagues online. Thumbs up if you can hear me. We're just waiting. Oh, I think we're here. So we've got a very, I think that, what time is it? 12 o'clock on the dot. Great. Thank you, Natasha. Appreciate the thumbs up and good to see you. Okay, colleagues, so we are a select but excited crew who have come to actually understand a bit of what Beth has been doing. We've been really pleased to have Beth in the Health Policy and Systems Division over the last couple of years, in fact, more or less. And unfortunately, she's leaving us soon. But it's a great opportunity for us and for those of you online to hear a little bit about some of the work she's been doing, not all of it. But the focus of the work, as per the title, is regional cooperation in health. And she's been doing a mapping of organizations and activities, I think. And this is early findings, as they say, work in progress. But Beth, we've really appreciated you being with us, and we appreciate you taking the time today to share some findings with us. And as you will all hear, those of you online, Beth is a senior policy fellow at the London School of Economics and Political Science in the UK, and this work is part of her PhD. So Beth, oh, come on in, Rashid, just in time. Beth, over to you, Maria. Thank you.
Reluctantly removing layers here, just about. Thank you, and thank you really to Lucy and to everybody for making me feel so welcome. I can't believe that 2 years has gone by. It feels, yeah. I hope I'll be back. And as oh, hold on, let me see. Let me just share my screen on here, and
maybe let's just double check if everybody can hear Beth. Thank you. Guys online, can you hear Beth? Great, thanks, yep. Natasha. You're good.
Okay, brilliant. So yes, as Lucy said, I'm based in London at the LSE. Normally, although I've been here for the last nearly 2 years, my role at LSE is very much a policy role. So I'm a slight interloper into an academic space, and I'm feeling my way and finding my feet. My day job is running the LSE hub of the African Health Observatory on Health Systems and Policies, which is a WHO-led knowledge exchange platform working with universities and ministries across the continent to produce evidence synthesis to inform policymaking. And the paper that I'm going to, or the work that I'm going to share with you today is actually something that has come, oh, let's see if I can change slides, maybe I can't.
Page down.
Down, no, space.
Mouse
click.
Lesion page down.
No. Oh, okay, we can do it with a click. We can do it with a click. It's actually something that had quite practical origins in the setup of the Health Observatory platform. When we were putting it together, we did what you would normally do when you start something off and look at what is already out there. And we were interested to see who the existing regional players were. At that time, with a focus on other knowledge exchange platforms doing a similar thing to what we were doing with the observatory. But it revealed the extent of the regional level architecture on the African continent, which was intriguing to me personally, and perhaps particularly at the time at which we were setting out was just pre-COVID, coming into COVID, and a time when suddenly you saw new players coming onto the African regional scene, so players like the Africa Centres for Disease Control, which raised questions for me about what those new players were doing, how we evaluate what they're doing, and how they perhaps disrupt the existing hierarchy. And that led to a dangerous next step of a PhD, which is focused on looking at the role of the contribution of the regional level to health, with a sort of case study focus on the African region. And so what I'm going to go through with you today is essentially the scene setter for that PhD. So looking at the existing, mapping the existing scope of regional activity within health within Africa. And it's then a precursor to some deeper dive papers, which will look at a case study of a particular organisation, specifically Africa Centres for Disease Control, and a specific role, so a role that regional organisations play, which would be regional governance, specifically looking at determining public health emergencies of international or regional concern and the capacity of regional organisations to do that, which is a timely one at the moment. But so today I will focus just on that mapping paper, just to give you, oh, it's working now, just to give you a sense of where this sits in the broader sort of disciplinary space. This is speaking primarily to a health policy audience, so speaking to health policy issues in terms of multilateral and intersectoral health governance challenges and how to address them, but doing so from an international relations, specifically comparative regionalist perspective. So that's more my background. I come from more of a sort of, I did IR previously and have worked in some consultancy, political risk consultancy, etc. So that's maybe bringing my focus to it. But also for me, with the relevance of comparative regional perspective in particular, foregrounds the value in looking comparatively between regions and across countries, and in studying formal regional cooperation. And a lot of the cooperation that we see within an African context is that formal regional, although we can discuss how much informal is going on as well, and the limitations of focusing on the formal. But it also foregrounds using interdisciplinary thinking to analyse health concerns. And so that is exactly what this paper does, is take conceptualisations of regionalism, regional organisations from the health policy literature, international relations literature, political science, social policy literature, and try to condense them to see how we can improve our understanding of what the regional level is contributing. As Lucy has said, I promised Lucy I'd finish this paper in time to present, but I haven't done it. So this is very much preliminary. You're getting the preliminary results and sort of the emerging findings. I have not done my analysis properly yet. This probably means this might be more useful to me than to you, but it will be really helpful to get your steer on what you think is interesting coming out of here and how we might take it further. Okay, so why this paper? What's the context? As Maylene and colleagues aptly demonstrated when I went to your policy workshop, health is inherently multisectoral and intersectoral issue. Current health challenges, opportunities, whether it's AMR, whether it's digital health, demand those cooperative cross-cutting responses. We know that the Sustainable Development Goals, including the health-related Sustainable Development Goals, are predicated on that type of intersectoral action. However, systemic weaknesses in the existing multilateral architecture are increasingly recognised, particularly post-COVID. We've seen a lot of criticism. We saw, particularly in low-resource settings, of vaccine nationalism, availability, criticisms of institutions, as well as the architecture. WHO, as we know, came under fire, and a lot of calls for a rethinking of what that architecture should look like. That's prompted a growing interest in the regional level specifically, across disciplines, so coming from a range of different perspectives, and depending on their perspective, they see a different added value for the regional level. So if you come from a social policy perspective, there's lots of suggestions that the regional level might address health inequities. If you come from a political science perspective, looking at bridging national regional divides, etc. And from the African context specifically, there's an immense breadth and depth of regional cooperative activity. According to the available data, we can discuss how limited that is. The African region has the largest number of regional organisations in comparatively across regions. And it's also very visibly leveraged, that regional activity, explicitly to address global governance failings. Get a number of statements by both politicians and health leaders that the existing architecture is not working for them and they need to act for themselves, and leveraging these sort of concepts of strengthening African agency and resilience to respond, and the value of doing so cooperatively. So hence the focus on the African setting. However, despite the interest in the regional, there is a distinct lack and an acknowledged lack of both empirical and theoretical evidence on regional activity. For example, there is no up-to-date mapping of who is who exists at the regional level and what they're doing. And there's a lot of criticism in the existing literature of the lack of theoretical application or the application of existing theoretical frameworks to evaluate activity. So it's both in terms of looking at intersectoral activity and in terms of looking at regional multilateral activity. So hence, my premise is that, as Deleuze says, for intersectoral action has become an unchallenged article of faith thinking, unchallenged article of faith in health thinking, that regionalism risks becoming the same unless we have an appropriate evidence base to address it. Hence, the aim here is to systematically map who is doing the extent and nature of African region cooperation. So who's out there, what they're doing, and to do so through the lens of a theoretically informed framework, so that we are mapping that activity against some of the existing thinking. Therefore, I'm using a systematic mapping review. My colleagues at LSE, most of whom are health economists, hate this because there are no dependent variables. It is purely descriptive. It doesn't go down well. I'm opting to justify it. But in terms of what we're trying to do here, where the argument is there is not enough data available to do the evaluations needed, it's actually very well suited, and it's quite a tight sort of process. It's intended to, it puts emphasis on identifying what evidence is out there, how it's dispersed, how accessible it is, and then in collating that into something new that addresses any evidence gaps identified, and then highlights areas for future research. So, but it is that, and it is no more. So don't ask it to do more, and that's what this will be. In that sense, so it follows a standard mapping process, identifying the scope, evidence base. And I'm going to take you through this very quickly, just because without understanding how we have sourced and categorized the data, it's hard to know what you can do with it. But I will try to do so speedily. So in terms of defining the scope of what we're looking at, this is a focus on regionalism and regional cooperation. So formal cooperation, this is interstate level cooperation, which means that we're defining regional organisations as institutionalised arenas. So they have to have majority member state membership. So they may have other members within them, non-member states, but the majority membership and majority governance has to be led by member states. So hence interstate. Not time bound, so these are not projects, they're definitely institutions. They have headquarters in the region. Their membership is defined by geographic criteria. So that's the take on regionalism and the bounding of that. Then taking a deliberately broad definition of health and health policy. So taking in mind social policy and equity-focused global health policy thinking, defining health policy as all government action to improve population health, and looking at health from a very broad take. And then we define the questions that we're looking at very simply as which ROs are active in Africa and active in health, which health areas are they working in, which roles are they playing, I'll talk a little bit more about what that means, and which goals are they aiming to achieve. Where do we get the information in order to do that? Conducted a literature review of the available evidence, both in terms of academic papers and in terms of grey literature and databases, that identified 6 existing data sets and plus some listings of African Union recognised agencies that weren't necessarily covered in that. And so that's the core source to give us a sort of list of organisations to go through. That gave us over 1,000 to screen, to see a sense of the sort of scope of it all. And then once we've screened that list, we've then chosen to use institutional websites to gather further information on what those organisations are doing in terms of where their policy focus is, what health activity they're doing, what roles they're playing. We chose websites because there are the most homogeneous source and because it's self-stated activity. And in line with the sort of systematic mapping methodology, the emphasis is on data accessibility, where it comes from. We're looking at formal interstate organisations, so websites, so outward-facing sources, and it allows us to say this is what the regional organisations themselves are presenting as what they're doing. So there's a choice there, and we can also talk about that and the limitations as to what those are. Okay, so that's your evidence base. And then in terms, we've then taken that evidence base and collated it to produce 3 new databases. So one of all of the regional organisations currently active in Africa, categorised by their primary policy focus, a database of all of those active regional organisations mapped by the health areas that they're working in, and then a smaller, more refined database looking at the organisations that have substantial activity within core health areas. I'll explain these terms a bit further in a moment, and mapping those by the specific roles that they're playing. We used 3 different tools or frameworks in order to do that mapping, some simpler than others. So defining the policy areas, a health-related SDG framework to define the health areas, and then a theoretically informed framework of roles and goals that we developed to map those. I'm going to tell you just a little bit more about those so that you understand how, again, we've broken those down. For the primary policy areas, it's very straightforward. We just use the African Union's policy areas. They have 6 policy or commission areas, and that's simply to enable us to understand, broadly speaking, what are this big data set of organisations, what's their core mandate. That. For the health areas, so again, this is in line with choosing a broad definition of health, but wanting to find ideally an existing framework that's widely accepted. So the health-related Sustainable Development Goals, 8 of the 17 goals are classed by the Global Burden of Disease Study as health-related. And within those 8 health-related goals, there are a range of targets and indicators. We actually make it up to 41. The Global Burden of Disease puts it at 33. We nuance it further, based again on trying to get a really broad definition of health and based on existing criticisms of the 33 that they reach. So we end up with 41 targets and indicators. You can see those here on the screen just to give you a sense of what they are. And we also distinguish within this, you can see the health goal, SDG 3, those are the targets and indicators for that, highlighted in red there, and then the broader health-related SDGs that are spread across the wider range of goals. We then, so when we map, we looked at everybody's websites, we looked at claims of activity across all of these indicators, purely on a presence-absence basis. If they claimed and said they did it, we clicked yes. We then did seek to substantiate those claims. We looked for examples of those activities being completed and graded those on a none, some, 1 to 9, or substantial, more than 10 for each activity. This is really simplistic in that sense. It's just an indicative idea of where these organisations are working. It's not an exhaustive record of what they're doing, or, and it's not intended to be. It's just meant to be an indication. So that's how we map the health areas. And then just briefly on the roles and goals. So this is trying to say they may be working in these different health areas, but what are they actually doing? How much do we know about what they're actually doing? So I did this bottom up and top down, so inductively saying within the literature, what does the literature say that regional organisations are or should be doing? And I've got a list of potential roles they could play. I then looked top down at existing frameworks, looking at sort of organisation capacity and what competencies are needed for multilateral action, what competencies are needed for intersectoral action. I actually ended up combining 2 frameworks that very conveniently you can see map onto each other. So a policy capacity framework from political science literature looking at multilateral action, and then a intersectoral engagement methodology from the sort of public health literature looking at what competencies are needed for intersectoral engagement. And they give you these both of these frameworks do look at the individual organisational and systemic level. I'm just looking at the organisational level for what I'm doing, but they do so across these three competency areas of analytical, operational, political. So that enabled me to then take the list of roles coming bottom up through the literature and put them into these three competency areas of analytical, operational, political, which is what you can see there. So on the left-hand side, you've got the roles that were coming through the literature, and on the right-hand side, you've got the goals. And again, that's something that came inductively through the literature review, that it was worth distinguishing between the roles, how organisations are doing things, and the goals, why they're doing them, because actually those are slightly different things. So that's how we collected it all. What did we get from it? In answer to the sort of first mapping question, who's active at a regional level, we had found over 1,000 organisations to screen. 124 of those met our criteria. So those are being dropped out based on duplicates, obviously, also based on no longer being active. So we included a historical database. So a lot of them were no longer active. It's also based on data availability, and that's one of the big stories coming out of this, that there was often not enough information there to confirm whether they're still active or to map what they're doing. So of the 124 that met our criteria, and also remember of those 1,000, a lot of those would have been maybe not African. We included databases that had both African and Middle East organisations, or they might not have been formal regional organisations meeting our criteria. So the 124 that met our criteria, 20 of them didn't have websites, so we couldn't map their activity, so 105. So we end up with a database of 105 organisations active in Africa, mapped by their primary policy area. Then went back to the websites of all of those 105, mapped their health activity, and 20 of those 105 organisations cited or reported substantial activity within SDG 3, the core health areas of SDG 3. So we chose to look in more detail at those 20 to what roles and goals they're playing, simply because the capacity to do that across all 105 was just beyond scope. What do we find? Very few regional organisations focus primarily on health. So of the 105, only 7 of them have health as a primary mandate. That doesn't, we know that this is a relatively crude tool, in that, for example, the regional economic communities, the big players on the regional scene, would all have been classed there as having an economic focus as their primary focus. We know that they probably do more than that. However, just as a sort of finger in the air, there's a very limited focus on health. However, when you drill down into what they're reporting doing, the majority of those 105, so over 80% of them, are reporting health activity across the broad health-related sustainable goals spectrum. And most of the activity that they're reporting is outside of SDG 3, so it's outside of core areas. Just giving a sort of a sense of potentially the intersectoral nature. We can't go as far as to say that, but we can say that there's you've got non-health organisations doing health work, you've got health organisations working outside of core health areas. Which health areas are they working in? So the top 10, this is self-reported activity, so what they're saying that they're doing. On the left-hand side, you can see this is by targets across the health-related SDGs. I think the takeaway for me on this is that very few of the core SDG 3 health targets make it into the top 10 areas of activity. So most of the top 10 areas are outside of SDG 3. Also, that epidemics are quite high up. That actually is slightly nuanced in the table to the right, which it breaks it down more by indicator, because you can see that communicable diseases and epidemics include HIV, malaria, TB. So once you take that out, it's slightly less dominant. That even in, sorry, I'm just moving this out of the way so I can see what I'm doing here. But even within these ones, there's a strong focus on malnutrition, poverty, disaster, rather than those core health areas. And then if we look at this, if we look at the top 10 areas within core health SDG 3, again, you're still seeing environmental issues, disaster ranking quite highly, even within that. And you're also seeing these cross-cutting areas like epidemics, UHC, NCDs coming in, again, suggesting a bit more of an intersectoral angle. What are they not reporting doing? They're not reporting doing sexual and reproductive health rights, which is interesting, given that if you go back one, they are reporting doing sexual and reproductive health services, but maybe in line with the recent furore at the World Health Assembly, they're not so keen on setting up a centre to provide the rights, maybe. Smoking and substance abuse gets the lowest number of scores very lowly. Perhaps interesting, given the sort of cooperative activity around smoking and the convention. Road traffic accidents also reporting very little, which perhaps is interesting given global burden of disease. Interesting to explore. Just to give you an idea of who are these sort of core health organisations. So those reporting substantial activity within core health areas. They're also reporting activity outside those core health areas, but they're all very well established. Most of them established pre-1990. Those that are established after 1990 are generally reincarnations of previous entities. All of the big players you would expect, the two WHO regional offices, the West African Organisation. Only 4 of the 8 regional economic communities, if you look at the literature on regional organisations, they're dominated by those regional economic communities. Only 4 of those are making it in here. And if we look at them, break them down a little bit further, they're very heterogeneous in terms of their policy focus areas. So a bit like the larger data set, they're working across all of the 6 policy focus areas in terms of their primary mandates. They are mainly cross-regional, which means that they're not fully, they don't have a membership of all countries on the continent, that have a subset of those, so they tend to be memberships of around 25 normally. And if you break it down again, there's basically one health-focused organisation per sub-region, broadly speaking. I'm going to skip over this. This is just giving you a rough idea of slightly more granularly the sort of examples we were counting, and in a way the depth of the data set, because that's the information we have across all of them. So whether it's COVID dashboards or strategic plans, that type of thing. Roles. So if we've looked at what health areas they're working in, what roles are they playing? I think, so if we take it back and say the framework that we produced for the roles was showing what competencies were needed for effective multilateral or intersectoral action. The takeaway for me here is that the ROs are actually quite well rounded in delivering across all the competency areas required. Individual organisations are not specialising. There is only one organisation that specialises in a single role area, and that is ECOWAS's investment bank, which just does training and capacity building, and that's mainly funding of training and capacity building. So there's perhaps an indication there that regional organisations are quite well rounded in terms of their capacities across competency areas. They're not delivering and implementing. A lot of the literature suggests that they might be coordinating resources, whatever. That's not what they're reporting doing. That's really only the core 3 or 4 health organisations that are doing that. And if you take out funding of implementation activity, we also track that through, there is even less activity. So there's really not much operational activity going on. The majority is actually political roles. That's the headline. And that's actually quite interesting if you break it down and you look, the health organisations are much more closely aligned to the political organisations in terms of their reporting than they are to the economic organisations. There's a definite division there. So they're leading and governing, not implementing. In terms of goals, advancing African solidarity and agency is cited by most incomes really high up. The economic organisations are not citing promoting health as a social good, and health organisations are not citing economic integration as a goal. It's sort of a, but again, there's also this sense that they're citing goals across a broad range of areas, and that political activity is it's aligned. The roles and goals data back each other up in terms of the goals reporting. So the mapping that is still to come, I haven't cross-mapped the roles and goals data properly. I hope there will be some stories that come out of that, and also against the policy areas to see whether particular types of organisations with a particular mandate are demonstrating particular activity. Just to highlight the limitations, limited data availability is a big challenge, and to be honest, is a finding in itself, that there really isn't much information out there. There's also not much information on the websites, and that limits the way we could map that. We can also talk about the extent to which it biases our data set to have just used websites and not to have used, for example, social media, if that is more widely used within the African region in particular. I think that has challenges in itself that we can discuss. This is also just a counting exercise. It does not tell you the scale, scope, or extent of the activity going on. We're counting on a 1-to-1, and that could be one report versus 100 million project. But there's no sort of differentiation there. But that's, in a way, that's not the purpose. This is just a baseline. It's to give you an idea of where these organisations are working. As I said previously, we've also focused on formal interstate cooperation. A lot of informal activity goes on. Are we really giving a picture of regional activity in health by just focusing on the formal interstate? And there are limitations by choosing to use the health-related SDG framework in terms of leanings towards quantifiable targets, but also that this is a health policy take on what health-related goals are. So, for example, it doesn't actually include education, which to me is a bit of a, well, so you might want to rethink about that. Emerging themes, just to give you a sort of sense of what's coming out. I think to me, it's the breadth of activity, a wide number of organisations reporting activity of a very different character. So it's the sort of intersectoral character of those organisations and the sheer number of them. It's complementing and perhaps consolidating some of the existing literature around what they've termed micro-regionalism, so the interactions between sub-regions and overlapping memberships between organisations. This is showing that that is definitely the case within a health space as well as has been observed more broadly. And I think there's more work to do there on what that means and the benefits of those overlapping memberships, or perhaps the duplication. The other story is sort of the breadth of health areas. As we said, the health activity is potentially under the radar, primarily outside of SDG 3, and then that they're going reporting activity across roles, leading, not implementing, and the dominance of the political activity. We've tried to do a bit of work to set this data in context, cognizant of the sort of limitations in terms of scope or scale. We tried to collect financial data for the 20 health-focused organisations in order to just give a sort of proxy for scale. The data is just not there. It's impossible to give you anything that you can compare it against. The next thing that we plan to do is to map against the GBD data on disease burden, just to look at whether the health areas that are coming up as highly cited, are they responding to disease burden or not? And similarly, can we do that against A flows to look at where they're responding to where perceived gaps are? Not done, but coming. So just to wrap up in terms of the takeaways within this systematic mapping sort of methodology, it is a contribution. However we wrap this up and whatever the takeaways are, the last comprehensive database goes up only to 2015. it finds 76 organisations using the same definition of regional organisations globally and 23 within Africa. So this is really opening up a whole sort of range of data and activity. And by doing so, using a new sort of theoretical framework, which is applying that existing thinking, and it's not going the next step to actually conducting the evaluation, but it's giving you a data set that is categorised according to theoretically informed thinking. And it's also pushing beyond existing scholarship, both in terms of focusing outside of the core health building blocks. That's where most of the literature at the moment uses things like WHO building blocks to look at existing regional cooperation. It doesn't tend to look beyond them. And similarly looking at actors beyond the sort of core actors. Most of the literature, again, focusing on regional economic communities or on the core health-focused organisations. So those with a health mandate, there's not much interest or acknowledgement of activity beyond that. So next, and this is where I would really welcome your views on where we can take some of this next. It's clearly signposting the need for further research, using different methodologies. Clearly, desk-based mapping has immense limitations. To look at both specific findings coming out of this and to map data further, but also perhaps to look at some of the dominant roles or health areas that are coming out of this. And that is clearly what I'm planning to do with the next papers in the PhD, in terms of looking at the dominant players that are coming out of this do match with the focus areas that I'm looking at in terms of Africa CDC and WHO, and in terms of the dominant role areas that are coming out also with leadership and governance, which matches where I'm looking going next. So, but thank you.
Great, thank you. Wow, I'm so stunned by the amount of work that has entailed. I mean, it's absolutely fascinating. I mean, it seems to me there's issues around methodology that are very interesting. Jill, your wider experience, I'm sure, is comparative in some way, or potentially so. Then there's the issues about the findings themselves, which is fascinating. And then there's the future. What is this a platform for, in a way? And so, yeah, let's open this up to questions and comments, and people online, we are keeping an eye out for you as well. Who wants to go first? Let's start with methodology. Jill, I don't know if you've got any reflections from the sort of other work that you've done, and similarities or differences.
Yeah, I mean, I wasn't going to comment on that. I mean, I think the systematic mapping, evidence mapping approach is rapidly growing as a really useful tool, because we have these very interdisciplinary areas that require broad scale, but it does, you do end up having a massive quantity of information.
You listen
Sorry.
to
No, I mean, it's just, I'll just comment on that.
Yes,
Yeah, I mean, I think it's just, I think we also find it really useful for these broad scale kind of questions. I was thinking about, with regards to this one, about how the speed issue, because the evidence, it moves and changes almost faster than you can map it. So I suppose with this one in particular, I did wonder if there was a anxiety around that and how that was managed. I'm more based. Do you want me to jump in with my other question? Sure. I don't know what you want to stick to.
No, you go.
Okay. I had a more. This might be a really stupid question, but I was wondering about the ones that you had found. I think it was the 124. How many of them are mandated and owned by African entities? I know it's a slightly fuzzy area. It seemed to me that many of them were, WHO observatories, CDMs, Africa CDMC. They still are mandated from global institutions, and therefore it's not a surprise that they made the advisory in role and capacity. And were any of them, other than the African Union, were any of the other ones actually like?
So our criteria were that they had to be majority African member state owned. So their governance structures had to be had to mean that decision-making power lay with majority African member states. So you're right that would mean that we would count WHO Regional Office for Africa as majority African member state owned, because their governance structure, the decision making is all member states on the regional committee choosing what they do. They may be following a global agenda, that their decision making about what they do is within that. The only exception we made to that was for some of the Arab organisations. Again, with a view to inclusivity, we chose to include a few of those where African member states made up about 45% of the membership, but weren't quite in the majority. But we felt that leaving them out would sort of distort the full regional picture, so we kept some of those in.
So they are African.
They are. I suppose that's the word. I'm sure I might be the right word. I suppose I'm just chewing over this idea about how strongly they are governed, guided, mandated by the global agenda, I suppose. I have no.
Yeah, that's interesting. I was wondering something similar. Where are the global influences on?
Yeah.
Which is why I wonder whether we might pull anything up with, I mentioned mapping aid flows. I was just interested to see whether there might just be any correlation there in terms of, and that's also why we tried so hard to get the financial data, to see whether we could see where they were funded from. Because it's fine that they might be majority governed, but where's the money? Yeah. That information is just not there. I mean, just not there from a debt-based mapping perspective. Clearly might be there.
Yeah. So I've got Eleanor mailing, but I've got Shiva online, and I want to make sure I give people online a chance. So Shiva, do you want to, I don't know if it is Shiva Global Unverified. Whoever you are, speak up.
Okay, thank you very much.
Great.
Can you hear me?
Yes.
Okay, great. Excellent presentation, excellent, amazing methodology, and the data which you've tried to access. A few questions and one or two comments. One is the regional organizations in Africa working in health. Don't you think you took on too much and expected too much possibility from data availability? And whether you had thought about just focusing on core organizations working on health, like, for example, the WHO Regional Office for Africa, East African Health Community, the slides which you presented, those organizations, their primary role is health. And then you have the others like SADC or African Union, where you have also a development role. So the question is, would it have been better if you had focused a little bit more on the health organizations per se more? Because I think it's a very ambitious, but your methodology is very interesting because one has to take forward the research is how effective and efficient are these regional organizations and what's the objective of regional organizations in health. And then the last point is your definition on health, which is a big problem, which we see everywhere. It is everything and nothing. And the result is that the results are nothing. And Africa is very badly affected by the lack of progress on health, especially the SDGs, and then also lack of progress in development as well as part of the globalization in the last 30 years. Thank you.
Thank you, Shiva. And Beth, I think if you could respond on those. And Andrew, I see your hand, but hold on.
Thanks, Shiva. I think in part on your first question, I in part agree with you, but this is a first step to further research. That's the nature of this methodology. And I would argue that the existing literature does focus on just those core health-focused organisations, as you suggested, and does sort of deep dive case studies into what they're doing. But what this data set is suggesting is that actually someone like SADC is not doing much in health. And so their inclusion as one of the core regional health players is perhaps a little bit erroneous because there's a much broader range of players at the regional level that we maybe should be giving more consideration to. However, I do agree with you that would we get more from doing a deep dive into a few of them using a different methodology or a broader range of methodologies? Yes, of course we would.
But there's also, that is your second step.
Exactly.
You will do a deep dive into at least one of them. Yeah. So there's other work to follow.
Exactly.
Yeah.
Yeah. And for the second question, hold on, that slipped my mind. That was
health.
Definition of health. Yes. This is something that we have struggled with. And if somebody can tell me a better one, then please do. I think all I can tell you is that the motivation here was to think about why we're doing this mapping, and that is to look at how do you evaluate the regional contribution. And if you're making hypotheses about what that contribution might be, then intersectoral and multilateral action is clearly a big part of that. And so having a health definition that was able to capture some of that action was crucial, because if we defined it too narrowly, we would potentially miss that. But I really do welcome your thoughts, because as I tried to point out, there are clearly limitations to that HRSDG bounding, and in a way, if I did this again, I'd perhaps choose from first principles what those health-related areas might be.
Okay, thanks very much, Beth. Andrew, hold fire. I'm just going to give somebody in the room a chance. Eleanor, you were next.
Thanks, Beth. Yeah, super interesting and really nice to see what you've been working on all this time. I was struck by that list of the sort of least recognized health topics. And I had two thoughts. The first one was, well, maybe it's three thoughts. The first one is, do you think some of that is prompted by this? Do you think that there would be a similar trend or pattern among the global health organizations, and some of that is like regional organizations picking up from that? Do you think there's some of those are like too political or too hot button or something, and that's why they're a bit neglected? And then maybe just the third one is, you know, we have like a framing for neglected tropical diseases, but we don't necessarily have a framing for neglected health issues that are neglected for very real sort of social and political reasons. And maybe that would be things to start talking more about.
I think exactly that, and I mean that in a way is where this now needs to go, is to say, okay, so why are those excluded? And we can make, and I sort of pointed to that a little bit, some assumptions about the fact that that's likely to be politically motivated. But this comes back to who's actually driving the agenda of these organisations and dictating what they can and can't do. And how do you uncover that? You know, I mean, really, the takeaway from all of this is just that we still don't know. Like, you know, at least now we've got some idea, arguably, about what they're doing, but why they're doing it and whether it's effective is still, you know, okay.
I mean, I was wondering whether the funding flows were dictating the topics and things, and the sexual and reproductive health rights versus services might suggest that, but needs more investigation. Andrew, online, over to you.
Thank you very much. So I'm Andrew Silomesi, joining in from Arusha, Tanzania.
Karibu sana bwana.
Asante sana. I work for the East Central and Southern Africa Health Community, which is an intergovernmental organization focusing specifically on health matters. We are very glad that we can see ourselves in the presentation. Great presentation, a wealth of information, and really a lot to think about. Just a couple of reflections, particularly with regard to what more can be done in terms of further finding out what is happening with regard to regional organizations focusing on health. I was just thinking that it would be quite interesting to see to what extent the regional organizations are actually interacting amongst themselves, what you referred to as the sub-regional interactions, in terms of finding common areas that they'll be able to work together in, as well as joint ventures, say, of resource mobilization. I think that there are definitely many synergies that can be created and many advantages that would be accrued from working together. So I think going forward, I would really be interested to see how much of that we can shed light on and see how we take advantage of these organizations collaborating amongst themselves. Thank you, and over.
Thank you.
Thank you, Andrew. maybe you are the perfect person then to test one of the findings that's coming out. At the sub-regional level, something that was interesting is that if you look across the full 105 organisations, West African organisations are dominant. There seem to be more of them than other sub-regions. But if you break down to the 20 organisations with substantial activity in core health, there is only one West African organisation, the West African Health Organisation. So it looks like their health activity is very much concentrated within that one. Whereas within an East African context, I think there are 3. And if you look at their role activity, they are very clearly sharing activity across the organisation. So one is focused on training and capacity building, the other is focused on research and development, one is focused on implementation. And there's a very clear commitment with one organisation simply not claiming any activity in a particular area, which is quite rare across the data set. So my sense, Andrew, is that in an East African context, there actually is quite a lot of potentially coordination at the sub-regional level in terms of health activity, but that's just an assumption based on what's coming out of this data set.
Andrew, just before we come back into the room, do you have any reflections on the assumption that Beth presented? Do you coordinate with your colleagues?
Yes, we have examples of coordination. For instance, there are a couple of, a number of projects that we've been running. Some collaborating, say, with SADC. We've collaborated very closely on a project that we've been focusing on TB in the mining sector. So there's a bit of that happening, but I think that it is important that we shed a bit more light on what further potential collaborations can be taking place, so that there's more of pulling in the same direction than duplicating efforts across the region. Yeah. And perhaps we'll make better use of the limited resources.
Yeah, great. Thanks, Andrew. Coming back into the room, Megan first and then Jill.
So maybe just one or two comments. Thank you so much, Beth. That was certainly fascinating. And for me, it's actually encouraging to see that there are a number of organizations that are not core health organizations, but that at least signal a sensitivity to health or health issues. And so it sounds as if the appeal for the health in all policy approach and so forth seem to have gained some traction. Of course, I mean, the issue is exactly what does that mean? How does it find expression? But the fact that it is at least visible and detectable in the data that you had collected is for me encouraging and hopefully would just escalate in terms of promoting intersectoral action for health. The second comment is that I think it's kind of related to Joel's question about whether the regional organizations simply follow mandates, even though they're classed as regional, they have regional member states. And just from a small focus study that we did on mapping global, regional, and country level policies around diet and physical activity, I think we found that the regional policies very much mirror and follow through global mandates, and there were very few specific policies that related to things uniquely to the African region or to specific sub-regions in Africa. So I think there might be some smaller studies around focus issues that might complement some of that question around how those mandates get expressed. And then I have a third issue which I forgot now, so I think
so I think those were comments. Maybe we can take Jill's point as well and then come back to you, Beth.
So there's nothing more frustrating than doing a mapping exercise and then have somebody ask you for something that's outside of the inclusion criteria. But I suppose that's what I'm going to do, is that it keeps on striking me that there's all these weird and wonderful examples of things that have that function but are not quite what you were classifying as a regional. And I just wondered if there wasn't a paper too that could come out of the study, which would be something like, descriptively talking about the kinds of, I mean, I'm thinking about the clusters of implementers who sit beneath a particular funder, for example, and they still function in that way of coordinating cross-regionally and engaging on implementation lessons and influencing policy, but they're not classically a regional cooperative agency that is mandated through the government kind of thing. You know what I mean? But they still have that role and function. And I suppose, and there are lots of examples of, I mean, as you know, there's lots of examples, or like regional networks of, I don't know, my work with the faith-based organizations where they regionally network themselves together in that way, but isn't, again, it wouldn't have been included. So I just suppose I wondered if there wasn't something descriptive that could come out where we could map out the weird and wonderful other things that have that function.
Yeah. So two things to say. One is that some of those weird and wonderfuls are in the thousands. But they do exist. For example, professional bodies. Or
union body.
yeah, exactly. Yeah. Or sort of NGO, disease-focused NGO bodies, that sort of thing. They are all in there, but they're not included. And to say that this is something that I sort of did think long and hard about, because particularly if you read the sort of social policy literature or some of the sort of equity-focused literature, there is a strong push, especially within the African region, that informal regional collaboration is actually what matters most. And that a focus on the intergovernmental is misleading in terms of what the benefits are. A comparative regionalist perspective would counter that and say, no, ultimately the power lies all. But yes, I think there is. I think the problem with doing that, and this is when I sort of was first thinking about how to bound this, is how you classify them and what you then, because then anything becomes the GDAR network, or at what level do you push it off? How do you say, even with this we struggled a little bit, because we said that there had to be member state participation, so you had to have policymakers sitting at the table, so we had to go in and look at the sort of membership of the government's committees, and if they included policymakers who were at sub-regional level, so Western Cape level or something, that would disqualify them technically, because we were talking about national policymakers, but there's a lot of organisations that have that cross. So yes, I agree. I haven't got my head around how. I think a descriptive piece is perhaps what it would be, a commentary that could talk about the wealth of that. But I think it's hard to systematically.
So I had one last thought before we wrap up. So you started off by saying, there's been a pressure towards, or there's been a drive towards regional action to address the global governance failings. And I wondered where this would go in answering whether regional organisations are contributing to rebalancing power. And that led me into the thing about, but who's funding them and what's driving their activity. But if I come back to Andrew's point on collaboration, I wonder also if the collaboration issue would be relevant to thinking about our regional organisations working together in ways that might allow some rebalancing of power relative to governance, to the global level. And my last question was, whose voice was it who said we need regional action to address global governance failings? Was it African governments or was it somebody else? African governments. Okay, so they should be interested in this study.
In theory.
In theory. Well, okay. Thank you very much, everybody. Thanks online. Shiva, I'm sorry we've got to wrap up because of the time. People are standing outside our doors to come in. But really appreciate everybody being online. Andrew, thank you so much for joining from Tanzania. And thank you to all in the room. And mostly thank you to Beth, and very good luck with the next steps of the work.
Thank you.
Thanks, guys, very much. And see you in the next noon meeting.
Thank you.
In response to your point there, Lucy,